Hi everyone, and welcome to the session on specialty interviews and F3 interviews. My name is Gemma Sinclair. I'm the careers lead for all of the F1s and the F2s in the Northern Foundation School. And in today's video, we're going to go through a little bit of a preparation for if you've got a specialty interview coming up, or if you're going for an F3 interview for a teaching fellow, a clinical fellow, or a trust grade. I'm going to take you through some of the interview stations that are part of the specialty interview, and then we'll do some preparation around the questions that you might get asked in a panel interview. So first of all, let's start with, if you've applied for specialty training, you'll get an email come through advising you that your interview is going to take place on what's called a system called CubiCom. This replaced Teams a couple of years ago when it comes to specialty interviews, and it is really much better than Teams. In the past, if you were doing a Teams online interview, you had the same panel of assessors going through your interview. So, if you did a clinical scenario with some assessors and then that didn't go so well, those same assessors would take you through the next part of the interview. Whereas with CubiCom, you're going to move through multiple panels. So you'll have your clinical scenario with someone, and then you'll move on and you'll do, say an ethical scenario with a different panel of assessors. So you'll get your email come through with your link to CubiCom to set that up. I have included on this video a link for you to go on and have a look at CubiCom if you kind of want to get a bit of a heads up on it and see what it's like, but you will get all of the joining instructions when you get your interview email come through. So when you go through on CubiCom on the day of your interview, you will be met by an admin person, and that admin person will do some ID checks with you. So they'll probably ask you to hold up your depends what you're using, passport or driving license, to the camera so that they can verify your ID. They'll ask if you're on your own in the room. They'll ask you to have your mobile phone with you but switched off in case there's any problems with the Wi-Fi. And in all of the years that I've supported specialty interviews, there's been a very, very small number of people who we've ever had to actually use the phone because their Wi-Fi hasn't been able to hold up for the interview. There has been situations where if people's Wi-Fi wasn't up to scratch, we would book them in the next day and ask them to go and find a more stable connection. And then the admin person will also kind of give you an idea about the structure of the interview. They'll give you all of the timings. If there was something that you needed to read at the beginning, there is sometimes situations where the first interview station that you go into is the clinical scenario. So they may share their screen with you so that you can read the clinical scenario. So you're not sitting in front of the assessors doing that and them waiting for you to then start answering the questions. As you go through the interview, the admin person stays with you. So if you're in an interview and you've got 7 minutes time for that interview, at the end of those 7 minutes, the admin person will cut whoever's talking off. So if you're in the middle of answering a question, or if the assessor is in the middle of asking you a question and those 7 minutes have run out, the admin person will cut you off mid-sentence. I know that sounds a bit harsh, but it's just making sure that it's fair for everybody and everyone has the same time. And then they'll take you through to the next station, and then they'll end the interview with you as well. So you're supported as you go through, and someone's keeping an eye on all of that. So when you get your email come through, it will give you a bit of an idea about what the structure of the interview will be. And this might already be information that's available in the applicant guide. It just depends on the specialty as to how much they share in terms of what the interview looks like. You will get some of them that give you everything. You'll have 10 minutes doing this, and then 7 minutes doing this, and then 5 minutes on a question on this. And then you will get some that are quite secretive and will just be like, you're going to have a 30-minute interview and it's going to be based around the things that are on the person's specification, and then you've got to kind of prep for whatever might come up. So I'm going to run you through some of the interview station. We call them stations, they're just parts of the interview for specialty training. So you've got your traditionally used to be called portfolio station, and a lot of people are starting to call it that again, but some people might call it application section. This is basically, if you have a portfolio, if you've had to upload evidence into a portal, this is where the assessors will have 10 minutes with your portfolio. They will go through it, they will check the scores that you've scored yourself, or if they are scoring you, they will go through and score it. They will look if the evidence is acceptable, and then they will come up with your score for your portfolio. Then you will come into the interview, and at that stage they'll have 10 minutes to talk to you about the interview, about your portfolio. Now they might be asking you questions directly related to a piece of evidence, or they might be asking you general questions around your portfolio. If it's a case that you haven't had to do a self-assessment and you haven't had the opportunity yet to talk about any of your achievements, it may well be that as part of the interview, the assessors will ask you questions around your achievements to date. So the likes of emergency medicine and anaesthetics who are using the MSRA, they will have questions in their interview which will ask you about your teaching, your audits, your research, what presentations you've done. So this might be part of that section if it's called application. There's sometimes for some of the specialties a management or a leadership section or a question that's in there, and that can be anything from surgery asks you to do a presentation on a management topic that they give you. Some of the other ones might ask you leadership questions around skills, leadership skills that you've got and experience of leading teams. There might also be, if there isn't an MSRA for your specialty, it might be that there is a SJT style leadership question within the interview that they ask you. So they give you a scenario and then you talk about how you would manage that using your leadership or management skills. Clinical scenario is a station where you will have a few minutes, normally 3, to read some information about a patient, and then you will have normally 7 minutes with an assessor, a consultant, who will then talk through how you would manage that patient's care, and they're scoring you as you go through on your clinical knowledge and your communication skills with that. Presentation is in some of the specialties. So for the likes of IMT, you have a 2-minute presentation at the beginning where you talk about why you want to do IMT and your commitment to that specialty. Some of the other ones have presentation topics that they give you, and then you present to the panel on those as well. Commitment to specialty. So this one sometimes has a standalone part of the interview, but sometimes it's included in some parts of the interview. So you might find that emergency medicine has an EM station, so you know you're going to get asked questions around that. It might be that there's a panel interview part, and then you know that there's likely going to be questions around why you want to do that specialty as part of the panel interview. But if you're looking at the format and the structure for your interview and you're thinking, actually there's nowhere in there where I can see where commitment to specialty might be coming up, it may well be that there's a question within one of those other stations that relates to commitment to specialty. And I'm going to show you some examples in this video of how they can pop up and how to spot them. Ethical scenario is medicine, where they'll give you a scenario and they'll ask you, and that will normally be something around patient safety or confidentiality or data sharing. It's one of those professionalism style questions. Mock consultation is role play. These were quite prominent before COVID, and now when we moved to Teams it was quite difficult to do role play, but some of the specialties are bringing them in, and I suspect that in the future we may see more role play come in once our applicant numbers have gone down and we're able to put more in the interviews. So this at the moment is being used by peds, neurosurgery, and either ophthalmology or histopathology. I always get confused which one does what. I'm sure it's ophthalmology has got a role play in there as well. So these are the things that you'll see either written down in the applicant guide or in the interview email. So you'll know that these things are going to happen and you can prepare for them. But this is not a medical interview in terms of, this is not conversations with consultants and then the consultants deciding who's the best doctor to take the job role. This is a job interview. And a job interview has to be run formally through a process, and that's a HR process, a human resource process. So basically every single question that you ask has to come back to a baseline of scores. So every single answer that you give in that specialty interview or in that F3 interview is being scored. Most of the time it's out of a score of 4. And if they're scoring you on things, it needs to relate back to an official document. And that official document for specialty and for F3s is the person specification that's linked to the job advert. So if you're looking at specialty, these are the things that are on the person specification. These are the soft skills which are on there. So you are going to get tested on some of these skills, and that might be your knowledge of knowing that these skills are needed for this specialty and being able to give examples of them, or that might be that they're going to directly ask you to give examples of them. For The specialties, these are the ones that are on most of them. There are additional ones on the ACFs and there are additional ones on public health. So make sure that you go and have a look at the person specifications for those, and you've got examples ready for the rest of them. So you're going to get asked, it might be 2 or 3 of these, a combination of them, but you are going to get tested on these and you won't know which ones you're going to be tested on. That's part of the interview. So you're going to have to prepare for all of them just in case. So I'm going to show you some examples of how the interviews are scored. I'm gonna take you through some videos. Now, some of these videos are old training videos which were used by NHS England, which used to be Health Education England back when we used them. So some people were recorded going through their specialty training interviews, and I'm going to show you some of those today. Now, they are quite old. They're pre-COVID, so they're in person, they're not online. And some of them will have physical portfolios in front of them, because it used to be that we asked the applicants to turn up with a portfolio in a folder of their evidence. Obviously now everything's online, so it's a bit different, but the questions that they are asking and the answers that they're giving and how they're being scored are very, very similar to what you would go through in a specialty interview today, so they're still relevant. So I'm going to show you the first video now, which is around, this is a portfolio station for anaesthetics. So you've got 3 candidates going through a portfolio station being asked questions on their achievements. Now, I just want you to think about what with the questions that they're getting asked, what do you think that they are being scored on?
Have a seat, Miriam. Right, so you're aware this is the portfolio room. Moving on then to clinical governance, you've given yourself a score of 3 for audit. Is that 1 audit or 2 audits?
I've done 2 audits.
Right, tell us about the best of those. Which one you're most proud of?
The second audit I undertook was about thromboprophylaxis in acute stroke patients.
So what was the standard you were auditing against?
That was a nice guidance.
Okay, and did the ward have a policy on thromboprophylaxis?
They didn't, no.
Right,
so following the audit, I then have put basically a summary of the NICE recommendations on. We had a ward poster with board with certain guidelines and information for people on there. So I put a copy of that on there. So and that's available for everyone to see now.
And how many of the stroke patients were having the correct thromboprophylaxis according to NICE guidelines?
They did sort of probe quite deeply into things and wanted to know more information about anything that you said. But then equally, I suppose you expect that you're going to be asked quite a lot about things and expect to really know.
Miriam, there may be things in your portfolio, perhaps achievements outside of your medical career that reflect on your future success as an anaesthetist. Is there anything you want to tell us about?
During university, I was in the Rambling and Hiking Club, and I was the secretary for a year there, which involved quite a lot of organisation, communication with different people, and prioritising. So certain jobs I need to do and things I need to arrange.
Anything else?
I've also been in an orchestra, and I play in the orchestra now.
Okay, what do you play?
I play the violin.
Good morning.
I'm David.
Hello, I'm Rachel Wolpoff from the Royal Gwent. This is Dr Jones.
Hi there, Dr Jones.
Hello. Have a seat. What was the research project you did as part of that?
The research project was on the direct effect of clopidogrel on vascular endothelium.
Right.
I think my year was hampered, unfortunately, by an injury I sustained at the start of it. I had 3...
What were you doing when you were injured?
I was playing rugby, of course.
Right.
And I tore a ligament in my finger and was unable to use it to take part in the project for about 3 months.
Okay.
So the 2-2...
That wasn't a good start.
The 2-2, for me, it represents actually a success to finish the year. I came very close to having to take a year out.
Okay. So he felt that getting the degree at all was a good thing. So that was important, because regardless of whether that's how he really feels, that's how he wants the interviewers to feel about him. So I think if there's things in your portfolio that are less positive, have a think about how you might be able to portray those to the interviewers in a positive light. If we come on then to the next section, which is clinical governance and audit, you've scored yourself 5 for that, which is have made a significant contribution to postgraduate audit projects. So tell us what you've done in your audit projects.
So I've been involved in 2 definitive audit projects, and one which I've sort of designed and I want to implement soon.
Tell us about the best of those.
the best of those is probably the one that is about to be presented in July of this year.
Right.
It's an anaesthetic on sort of perioperative fasting times and looking at how long patients are fasted for and what advice they're given, and also the staff knowledge as to how long they should be fasted for prior to elective procedures.
Okay, and what did you find out?
Well, the reason I did it was because I thought that there's a sort of a vast difference between how long we starve patients for and how long is recommended. I think we starve patients too long in a lot of...
Did your audit show that?
Yes, it did. It showed big differences in terms of knowledge and also big differences in terms of how long patients actually starve for. Some starve for 24 hours prior to operation.
Hello, I'm Dr. Orr from the Royal Gwent. This is Dr. Jones from Bridgend.
Hello.
Have a seat. Have you also done a foundation post in anaesthesia?
So I did that as my first F2 rotation in Bridgend, and it was a half ITU and half anaesthetics post.
Okay. And how did that confirm for you your desire for a career in anaesthesia?
Well, I mean, it was really sort of speaking to the consultants and finding out what they did on a day-to-day basis, and I just really enjoyed it. I liked the whole atmosphere of theatres, the whole atmosphere of ITU, and the sort of it was very much the specialist side of sort of looking after the airway that I found that it was something that really interested me. Mm-hmm. I was never really bored during the job, which was pretty good.
Is there anything from outside of medicine in your portfolio that you think will reflect on your future career as an anaesthetist or make you a better anaesthetist?
Well, I know that when I was doing my anaesthetics job, I was actually training for an Ironman that I completed.
So just remind me what an Ironman
is. It's a triathlon where you swim 2.5 miles in the sea, and then you cycle 112 miles, and then you run a marathon.
Right. Now, why would anyone want to do that, Stephen?
It was the achievement, really, and just knowing that I could do something that I thought was physically challenging, and initially something that I thought was beyond me.
And when you do an Ironman event, is that about you, or is there a team aspect to it?
I mean, the actual event itself is all about you, but the majority of actually completing the Ironman comes from the training, which is actually about everyone in your life.
So what are you most proud of in this portfolio?
Well, it probably is the Ironman.
So what did you think about that portfolio station? Is that what you were expecting? A little bit too harsh, a bit too soft? When I deliver this in person, the group always is a little bit put off by one of the assessors because she's finishing some of their sentences and she's interrupting them sometimes. The reason that she's doing that is not because she's particularly a bad assessor. It's just because it's a timed interview. So if you have 10 minutes, they're going to try and get you through those as fast as possible to maximise your opportunity to get points. If you are going off on a tangent and it isn't about what they've got points to score you on, and it's not relevant what you're saying, they will pull you back in and try and get you back on track. If you have already said everything that you need to say for those 4 points and you're still talking, they will try and shut you down to move you on to the next question to give you the best chance of being able to get more points for that. So let them guide you a little bit and don't be put off if they are interrupting or bringing you back to something, because they're just ultimately trying to help you as much as they can with that interview. So if we look at those 3 candidates, what were they being scored on? So I think they were being scored on 3 things in that interview. The first one could be one of 2. So we've got either audit, because they were asked questions about their audit. Now in this situation, they'd already self-assessed themselves. So if you're going for something where you have completed a self-assessment already and you've scored yourself, it could be that in the interview, if they ask you about audit and you've already had allocated and verified those points, that this could actually be 4 points that are allocated to your communication skills and how you talk through your audit and present it to them. To be on the safe side, if you're going into an interview, I would make sure that you have already prepared and can talk through in a very clear and succinct style for the 4 big achievements. So that's audit, teaching, presentation and research, yeah? And you want to be able to really give a good overview of that and get through that quite quickly. So I decided to do an audit for this reason. There was an issue with this. I led it this way. There was a team of however many. This is how we collected the data. This is how we analysed it. This was the result of that. This is what we put in place. And then when we did the check, this was the results of the implementation of that change. You're giving a nice overview, beginning, middle, and end story of your example of audit. If you do that, you're less likely to waffle, you're less likely to in the middle of it. And I would do that for those 4, just in case you are being scored on your communication skills during that part of the interview. If you've never let them know about your audit, if you're going for something where there wasn't a portfolio, there wasn't a self-assessment, there's nothing in your application form about your achievements, then you could well be being scored on audit. And again, still you need to talk through that in that style to give that example. The other things that they were being scored on. So they were asked, what do you do outside in extracurricular which would reflect on you being successful as an anaesthetist? This is basically a skills-based question. What do you do outside of work that's developed your skills that would help you to work in anaesthetics? Now, your first candidate said that she was in the Rambling and Hiking Club, which she did then follow up with some skills. So she said that was really good for her communication, organisation, prioritisation, which are 3 skills which are on the person specification. So she is going to pick up a point for that. But she didn't go into any further examples of how she developed that skill while she was doing part of this Rambling and Hiking Club. Now, what she could have done was she could have prepared something before the interview that showcased that. So actually, I'm in the Rambling and Hiking Club. That's really improved my communication, prioritisation and organisation skills. An example of that is we put on a charity hike. I used my communication skills both through orally talking to people and promoting the event, and also written by sending out emails to people to ask for fundraising for it. Prioritisation was where we sat down together as a team and we looked at what we needed to take with us, who was better at doing what tasks, prioritising what was more important on the day in terms of, I don't know, what we put in our bags and who went up there first. I don't know, I'm making this up, I don't ramble and hike. And our organisation skills of how long it would take us to get up there, how long it would take us to get back. Do you see how now you're building this real example of how you've demonstrated those skills and used those skills in a real life situation, which is so much stronger than just saying, I do this and it's give me these skills. This is how. You're giving them that extra. So if we're talking about you listing a couple of skills off the person's spec, you're talking about 1 point out of 4. If you're then giving an example, depending on how strong your example is and how many skills it shows out and how you demonstrate that you've got them, you're looking at 2 or 3 points. Your 4 out of 4, you're getting from the back end of that question. So it's, what have you done in extracurricular? That would reflect on you being successful as an anaesthetist. So it's not just saying you've got the skills, it's not just giving us an example of where that's from, but it's also telling us why those skills are important for what you're applying for. And actually, I think these skills are really important because when I was on my anaesthetics rotation, I realised that prioritisation plays a big part because I witnessed this and I've seen the team do this, or organisation or communication, yeah? Then you're reflecting it back into that. That is going to give you your 4 out of 4 points. The Ironman guy, he has fell into the trap of, this portfolio section of the interview is just where I talk about my achievements. Yeah, I don't need to go into loads of detail. We're just verifying points here. We're just going through it. And he hasn't realised that actually there are some big points here. That skills-based question that he got asked, the same question as what the rambling lady did, when she said, why would anyone want to do an Ironman? That was your chance to talk about the skills. Can you imagine what skills you would need to do an Ironman and be a foundation doctor? Your prioritisation, your time management, your coping with pressure, all of these things would tie in with that. His response to that was just, the event is all about me, but the training includes everyone in my life. Like, we're not getting any points for this when it comes to these skills. She then followed up with it with a prompt question, which they can do if they feel like they're not getting anywhere with you and you're not getting any of the points out of them. She said, is there a team aspect to that? That is literally handing him 4 points on a plate. If you hear one of those skills from the person's spec being mentioned in one of the questions in the interview, that's a light bulb of, she has 4 points there for teamwork. And then you give that answer. And again, just fell into this whole trap of talking about the Iron Man and showing off about the Iron Man. Now, if you've prepared something, if you've already looked at all of those skills on the person's spec, whether this is specialty or F3, and you've got your examples ready, you then don't have to think on your feet. You can just pull that example. And if you were caught off guard with a question like that, where, you know, your example that you've got is a really good example of a time when you've worked during one of your rotations in an MDT team, and that's what you're going to use for teamwork, and they ask you something about extracurricular, you can just say, well, actually, the things that I do outside of work don't overly showcase my teamwork skills as much as an example that I've got from work. Can I talk to you about that? Can I tell you about that? They're not going to say no. They've got 4 points on their sheet for skills. As long as you demonstrate your teamwork skills and then why that's important for whatever it is that you're applying for, you will get the full points. So then you can have that there and ready. I see a lot of foundation doctors who think that because they have a really strong portfolio, which is great, I know you've worked really, really hard for that, and it's difficult to get those opportunities, but please don't rely on those in the interview. It might be that those got you through the door for the interview because that was part of a portfolio or a self-assessment, or you're going to talk about them in the interview and you know that they will look impressive because you've put a lot of work into that. That's great, but don't rely on that on its own. It's not enough to get you the job. The interview is a job interview. You need to be able to answer these questions. And if one thing you can take from this video today, it's that preparation is key. If you prepare all of these examples so that you have everything ready to go and you've got this backpack of stuff that you can just use, you're going to score, you're going to do well, you're going to score well in that interview. And I get a lot of people who come out, if they've done the prep and they go, oh, you know what, I had like 3 more examples that they didn't want, they said they had enough. Rather than come out of there and be like, oh, I could have said that, oh, I should have said that, oh, that would have looked really good if I hadn't mentioned that, and I just didn't think about it at the time. Preparation is key for this one. Okay, so the last thing that they were scoring in that video that you've just seen on the portfolio was commitment to specialty. And that got asked to the Iron Man guy through the question of how did your rotation and anaesthetics, I can't remember the exact wording, but make you decide that this was the career choice for you. It's basically a what have you learnt about the specialty and why do you want it question. Now, when we're looking at a commitment to specialty question, you need to be able to give a really well-rounded and really in-depth answer to this. Again, this Iron Man guy has fallen into the trap if I'm just talking about what's in my portfolio. So the fact that I've got the rotation and anaesthetics has probably put me in a great place. So I'm just talking through that. But actually, this was your interview question on why you think you're matched to this job. His response to it, if we're looking at this 4 out of 4 points, was I enjoyed it. I like talking to the consultants, something about a special side of the airway, and he didn't get bored. How many points out of 4 are we going to give him for that? He might pick up 1, but very close, because really all he's saying is he enjoyed it. What you need to be able to do is come up with a kind of 3 parts of this. Why do you want that job? So actually, I think that the reason that when I was on my rotation at anaesthetics, I discovered that actually some of my strengths are teamwork or this. Talk about your skills, talk about how you've used them, talk about how you've identified the fact that within that specialty, you can see that they're useful. What you learned from that rotation. What did you learn about that specialty? About how the trainees work, about how the consultants work, about the day-to-day parts of the job and how they match up with you and why you would find that satisfying. Yeah, it's all about how well do you know yourself and how well do you know that job to be able to show that it's a well-considered decision. And then on the back of that as well, the third thing is also having this sort of long-term, short-term career plan that you can talk about in there as well. So actually on my rotation in anaesthetics, I discovered that I worked really well within a team, and I've seen how important that was as I was watching all the different parts of the team while they were doing, I'm not a medic, I don't know what it's like when you're in your anaesthetics, but you know, talk about that side of it. This is what I learned from the trainees. Actually, I seen that they needed to be really practical, they needed to be really I don't know, confident with procedure. They needed this, they needed that, whatever it is that you've witnessed, and then you're relaying that back. And actually, I've seen from the consultants that they had this level of responsibility. I feel like I would handle that really well. You're digging into the different parts of it and why that then is good for you. And I think that's a really great way. Don't just talk about what you've seen. Yeah. I was always on the anaesthetics rotation. I spent 2 weeks on ITU. I spent 2 weeks doing this. I was in theatre this many times. All you're doing is listing things. You're not actually feeding anything back in to your self-awareness stuff around why then that suits you and why you would be good within that role as well. So don't fall into the trap of, oh, there's a panel interview bit later on, I'll get asked about why I want the job then. This is just a portfolio station where I'm talking about the stuff that I've done, because actually you could really waste 4 points there. And your 4 points at the moment with the competition rates as they are is the difference between sometimes getting a job and not getting a job offer. But once prioritisation comes in and we go back to training posts or the increased training posts being more accessible, this could be the difference between the rotations within the deanery and which ones you want and your preference in, because all of these points add up to your final rank score, and that dictates the job offer that comes through at the end of it. Okay, if we look now at clinical scenario. So for your clinical scenario, you will get given a brief that you will read for a few minutes, take in the details around what's going on with the patient, and then you will enter the interview, and you will probably have either 1 or 2 consultants who will talk you through what's going on with the patient, and you'll answer their questions and talk through how you would manage that patient's care. Now, I have seen quite a lot of clinical scenarios over the years of shadowing in interviews, and there is a format that you need to follow, because again, it's not a conversation with a consultant about a patient's care. It's not something that you will be doing like on the ward. It is a job interview. It has a structure behind it. They have to be able to give feedback on how one candidate did in the station, so it will be broken down into these are the things that the candidate needs to say to be able to get the points. So there is a format to this when it comes to answering clinical scenarios. So I'm going to run you through that, and then I'm going to show you some examples of someone talking through a clinical scenario. So first of all, I would say the number one pitfall mistake that people make when it comes to a clinical scenario station is that there is normally some points allocated at the very beginning of the clinical scenario for just stating 3 things, and a lot of candidates do tend to just skip this and go straight into the investigation skills. So these things are, you should verbalise to the panel, this is what I think might be going on with the patient. It might be this, this or this. You should then also state if any of those things could potentially lead to a high risk situation. And if at this point in time, there would be anybody else that you would seek some input from, so any other teams or departments that you would need to get involved at this stage, there's sometimes a point allocated for that. Then go in to the investigation stuff. So go through your A to E, whatever other alternative it is to going through the initial investigations that you would do in the history taken and the check-in notes and things like that. Don't spend ages on this bit, okay? Everyone who's applying is a doctor. Everyone knows how to do A to E. Don't spend ages and ages going through this. Do it quite quickly. If there is anything that you are talking about which has acronyms, you do need to say what those letters stand for. We're not talking as in how you would talk to a layman in layman terms. Just somewhere in between consultant and layman, just lean it there. So if there is an acronym, what it stands for. If there is anything like that that you wouldn't normally further explain it. After you've done the investigations, you will get to the point where the consultant will give you a prompt, and this will probably give you a direction as to what the diagnosis is. Most of the time this will then lead to a handover. So it might be that you'll do some additional tests, do additional checks at this point. It might be that you give medication, so there are sometimes points there for what medication that you would give, so mention anything like that. But then this is going to lead to a handover, and you need to be able to talk through the handover. So make sure that you explain who you would hand over to, and then go through the whole handover as if you were talking to that person. There are also sometimes some points allocated for anything additional that you would do at the end. So if there was somewhere that you would refer to, sort of like an outreach team or community team or mental health support or social services, anything like that, you can put that into the end as well. So I'm going to show you a couple of videos. These are off a guy who's got a YouTube account who has been through core surgical training interviews and is talking about how to format the answer. Now he's going to give you a weaker version, he calls, which actually is a quite standard of what you see people come through and do. And then he's going to give you one where he's following a format, but obviously he's not giving you the format that's the exact one, but it's close enough to the one that I'm talking through, so you can see kind of how you would lay out your answer. So let's have a look at these.
Example of a weak or average answer that includes a few pitfalls that people tend to make. For that, I'll use an example that I made up, which is: you are the core surgical trainee on call and the nurse calls you about a 60-year-old patient who has developed a fever after his abdominal surgery. What do you do? I would start by performing an A to E assessment. For airway, I'll assess the patient is talking and has no secretions by the mouth. For breathing, I'll examine the chest, take bloods for a blood culture and routine bloods, including group and save and clotting. I'll then contact my registrar on call. The patient is 5 days post elective anterior resection, has a fever of 38.8, tachycardia and hypotension. He is peritonitic with rebound tenderness and guarding in the left iliac fossa. His lactate is 3 on the blood gas and the chest x-ray is unremarkable. I'll start the patient on antibiotics and I will contact my registrar and tell them that this patient might need to go for an operation.
That's quite typical of what you would see come through. Skipping that bit at the beginning where you're seeing what might be happening, jumping straight into the investigation and the initial investigation skills, spending ages and ages talking through those, and then wrapping up at the end without enough detail and in depth. So let's have a look at the good example now.
Put this all together into an example of a better answer. I'll keep it a little bit abbreviated just for time, and it's more so that you see the structure and flow of the answer that's important. Also, please bear with me because it's been about a year since I've done this. This patient has a post-operative pyrexia, and my main concern would be sepsis, possibly due to a complication from the operation. The other differential diagnosis is a normal post-operative pyrexia. However, I cannot rule this out with the information I'm given. Sepsis isn't a medical emergency, so I'll need to go and assess the patient immediately. When I assess the patient, I'll ask the bedside nurse to join me and assess the patient in an 8E manner according to advanced life support guidelines. For airway and breathing, I'll ensure they're talking and I'll examine their chest, record respiratory rate, saturations, request a chest x-ray and apply 15 litres of oxygen through a non-rebreathe mask. For circulation, I will assess their fluid status, including peripheral perfusion. I'll ask for the pulse and the blood pressure and establish wide bore intravenous access in order to take routine bloods, including group and save and clotting, as well as a venous blood gas. I would also start intravenous fluids. For disability, I'll assess the patient's consciousness level, pain, and also their blood glucose from the blood gas, and I'll ask the nurse for a temperature. In exposure, I'll perform a top-to-tail examination, focusing especially on the surgical site to look for any evidence of peritonism. Following the A to E, I will ask a focused history from the patient for when their symptoms began and if they have any associated symptoms such as vomiting. Following this, I'll review the patient's notes, especially their operation note, to see if the operation was difficult. I'll review the anaesthetic chart to see if they were unstable in the procedure. I would also look at their drug chart, clerking, and observation chart. As this patient has a fever day 5 after abdominal surgery with a bowel anastomosis, I'm concerned about an anastomotic leak causing sepsis. This is a surgical emergency, and as there is sepsis, I would like to ensure I complete the sepsis 6, which is to take blood cultures, venous blood gas, insert a urinary catheter for fluid output monitoring, and also start oxygen, IV fluids and antibiotics within the first hour. I would also like to inform the registrar on call to tell them about the patient. I'll explain the main differential diagnosis is sepsis due to anastomotic leak. With a patient that's hemodynamically unstable with a raised lactate, I'll explain what I've done so far, which is the sepsis 6, and I'd recommend that this patient might need to have a CT abdomen pelvis with rectal contrast. As this patient is unwell, I would like to escalate to the critical care outreach team to get some further support, and if he does not improve with fluid resuscitation, then we may need to contact intensive care. After the patient has been stabilised and treated, I can think about reflecting on this scenario for my portfolio, as this was a good learning opportunity. If there is indeed a complication, then this will need to be recorded in the morbidity and mortality statistics and presented at the next clinical governance meeting. In addition, to further the educational value from the case, I could prepare a case presentation for my colleagues and discuss the management of the septic general surgical patient.
So do you see how that follows a format? It's not naturally what you would do if you were talking to a consultant. And I think if you are going to do a clinical scenario, it would be good to probably practice just doing this, going through this layout, just with any kind of general clinical scenarios that come up day to day in your job role. You do have a bit of paper and a pen. You're allowed that in the interview. So if you are going through the brief and you want to kind of write down a few things so that you follow that and you don't forget anything, then you can do that, and then you can talk to the panel and refer to your notes when you go through it. I'm just showing you a slide now so you can see some other examples, so it isn't just surgery that we're talking about. So we've got a gastro one, emergency med one, and an obs and gynae one, and then you can see there the format that I've just talked through there, what level of risk, your investigations, you're going to get your prompt and what actions you do off the back of that. You can see the gastro one's got some points for medication there, and then who you're escalating it to, how you're doing the handover, and gastro's got a little points in there for some additional stuff that you would do after that as well. So it's just about talking through it in that format. And actually, you know, if you don't spend ages on that middle bit and you get through to the end, there are sometimes some easy points to pick up at the end. It tends to be that the beginning of the clinical scenario is a lot of you talking and the consultant will be scoring as you're going through. If the consultant is writing things down or they're not looking and they're typing on something else while you're answering, you're doing the right thing, they are scoring you as you're going through. If you're not on the right track and they're looking at you and they're trying to stop you and trying to interrupt, it isn't necessarily that you're doing this wrong, it's just that you've gone off away from whatever it is that they're scoring you on. So it's really important to allow them to guide you a little bit. If they look as if they want to stop, you just let them, and then let them guide you through. And yeah, if you get through that bit, sometimes there's some really easy stuff to pick up at the end where they'll just be asking you, like, what does this stand for? What point would you expect to see on this test? Those kinds of things that you can answer really quickly and gain a lot of points from. So we're going to move into panel interview. Now this is relevant for some of the questions will come up in the specialty interviews, but also I'm going to go through the format of how an F3 interview will take place as well, just so you can see the format behind that. So for panel interviews, if you're going for a trust interview, the first job that you're going to get asked questions about is questions about you. It's supposed to be, the idea behind these is supposed to be to kind of relax you into the interview, but actually a lot of people hate these questions. So they're questions like, tell us a little bit about yourself, tell us about why you've applied for this post, tell us about your experience so far. It's those kinds of things. And I think that people panic because they're stressed and they're in an interview and this is the first question that they get asked, and also are a little bit like, how much detail do I go into here? How much do I tell them? Again, if you've prepped this will be easier. So if you've thought about this before the interview, if you've wrote it down and memorized it, whatever works for your learning style, I would make sure that you have a little succinct statement about yourself. This is who I am. These are my personality traits, my attributes, my top skills. This is what I'm interested in. This is my career goal. These are the things that I've explored it and how I've explored it and the achievements that I've got up to date that are relevant to it. And this is my sort of short-term and long-term career goal as to where I want to go. And it doesn't matter if you are applying for something like medicine and you don't know what higher specialty that you want to do later on. It isn't that you're going to get scored down because you haven't made that career decision yet. If you have, that's fine, talk about that. But if you haven't, you want to say things like, and this is why I hope to explore during IMT. I want to look at, neurology, cardiology, and gastro. And this is the reasons why I think I might be suited to them, and this is why I want to explore them more. Yeah. So I'm going to show you some videos of people going through the IMT ACCS Internal Medicine, or used to be acute back then, interview, just so you can see the difference between somebody who has prepped and somebody who hasn't. So here's a video of somebody who hasn't prepped.
Medicine.
I think for me the reason I want to apply to medicine is that with all the jobs I've been doing thus far, from A&E to oncology to ITU, the bit that I've most enjoyed is the medicine, and specifically the acute medicine. So I've enjoyed looking after, for example, the ACCS, the acute coronary syndromes, diabetic ketoacidosis. It wasn't always the case. I wasn't always thinking of medicine. I thought my path would be very different, so it was a bit of a surprise, but that's what I've enjoyed doing. That's my motivation.
So you can see there that she's not really going to get a lot of points for just saying that she enjoyed it and it surprised her. And again, it's one of these thinking off the top of your head when you're in an interview situation. Most people get stressed or have some element of stress from an interview. They say that it takes 90 seconds when you walk into a room to be able to relax enough to be able to think off your top of your head for an answer. It's probably worse when it's online because you can see yourself looking back at you as well, and your brain is just taking in what's going on and eye contact with people and getting comfortable with the situation. So it's hard to think of something and come up with these examples and reasons if you're just asked straight out what it is. It's also quite good if you've prepared it, because if you are extroverted under a stressful situation, when we're stressed, you tend to go off on a tangent, and this is a really good baseline to pull yourself back down to. Also, opposite end, if you're introverted, you do tend to have a tendency to just go blank and you can't think off the top of your head. So if you've revised this, memorized it, it's easier to be able to pull that information. And I think if you answer well in the first question, it settles you in for the rest of the interview, whereas if you feel as if you haven't answered that as well, it's going to knock you off for the next couple of questions and take a bit longer. So we've got questions about you, then it will move on to questions about the job. So this is like, how much have you researched the thing that you're applying for? So if it's specialty, it's about what exposure have you had to it? Do you understand what it's like to be a trainee, what it's like to be a consultant, what it's like to do it in a district general compared to what it's like to do it in a tertiary hospital? What's the curriculum like? Make sure that you revise the curriculum. It may well be that they ask you, like, what are the mandatory parts of this training? And you'll need to know, like, I rotate every so often. This is when I need to do the exams. These are the parts of the mandatory curriculum that I need to learn. So it's really good to be able to show that you've done some research around those. So I'm going to show you, F3s just as well. Just make sure if you're applying for an F3, you've researched that, so you fully understand the role of that clinical fellow or that teaching fellow, all the different parts of it, and the trust and that department. If you're going for something, that you've looked into the details of that as well. So I'm going to show you an example of somebody who is going through some questions about themselves, commitment to specialty, and questions about the job. So let's have a little look at that.
Hi, nice to meet you. I'm Steve Riley.
Hello, Peter Neville. Do take a seat. So where do you see yourself in 5 years' time?
I think 5 years' time, I'd like to see myself with an ST post in intensive care. I've got particular interest in medical education as well, and I've undertaken programmes with medical students, teaching them fluoroscopies and ward-based teaching. So I'd like to perhaps be doing an MSc in medical education with the view to having that as a particular interest as a higher trainee or consultant.
Okay, so we've got a bit of a commitment to specialty question. So like, why are you interested in the job? Yeah. Where do you see yourself in 5 years' time? He hasn't answered that great. He's answered that he's interested in intensive care. Now, this is the IMT ACCS internal medicine interview. So intensive care is not a training program in this pathway. It can be dual accredited with some of the specialties in higher medicine, but it isn't standalone training or part of IMT training. So he's not going to pick up any points for commitment to specialty because he's not talking about the right specialty. He has mentioned med ed. Now, I know your job is enough on its own. You shouldn't have to do anything extra, but you know, the world that you live in, they do like to see you doing additional things. So if you do have an interest in med ed, research, leadership, health, informatics, digital tech, anything like that, that's kind of those are the more popular ones that are coming up now. Sustainability's in there as well. If there's anything like that you're interested in and you want to combine that with training at some point, it probably is worth mentioning it in the interview. It does look good. It might pick you up an extra point or two. So we haven't got any points for a commitment to specialty with them, so they're going to prompt a little bit more because they've got points for that. So let's look at what else they ask.
Have you had any thoughts about which specialty you'd choose if you were pursuing that sort of...
I think when choosing a specialty, it's always very important to look at what the consultants are doing. I think what you might enjoy as a trainee often becomes very different as a consultant. So I think that is something to bear in mind.
So either he's really panicked and he hasn't thought of anything and this has just come out, or for me, if I was the assessor, if he's not able to identify a specialty that he's interested in within medicine, that would make me think that actually that this is not the job he wants. Maybe he's a backup choice and he actually wants anaesthetics or emergency medicine and to do that with intensive care. If you are going for something as a second choice, you've got to pretend it's your first. And I know a lot of you will be applying for a lot of F3 positions. You're really going to have to talk about those F3 jobs as if you want them. I know that it might not be your first choice and you might accept something and then find the thing that you want later on and go back and turn the first one down, which is fine. But in the interview, you need to make out that that's your number one choice. So we're going to keep going with this. They're going to ask a slightly different question to still pull some of that out, but we are starting to get to the end of them being able to prompt on this commitment to specialty now.
How have your rotations and attachments that you've done so far since qualifying helped to shape your thinking about this specialty?
I set out with the aim of providing myself with a broad base of postgraduate experience during my foundation years. So my first year involved cardiology and respiratory medicine, with obviously a lot of physiology involved in that, and acute and chronic disease management, things that are particularly pertinent to intensive care. For my second year, I've also done accident and emergency medicine and anaesthetics in intensive care. I think with those jobs in mind, I've developed a broad skill set, including sort of managing multiple pathologies at once, critical thinking, and obviously the practical skills that are particularly important in acutely unwell patients.
So there is no point in the specialty interview in listing your rotations. Everyone who's applying will have done a variety of rotations. It's just wasting your minutes in the interview by listing them. They're already in your employment history in the application form anyway, so if anyone did want to go and have a look and see what you'd done, they could go back and look at it. Not that the assessors really would. If you're bringing up rotations, it's about what you learned in them specifically to your career choice. So what you saw, what you had experience of, what you learned that helped to make that career decision for you, not just listing what you've done. He has gone into skills. The skills that he's listed are, well, one of them's on the person's spec, critical thinking, but the rest of them are not on the person's specification. So he's not going to pick up any points for them. And he hasn't gone into any big detail of them. But because they have got points on their score sheets for skills, they are now going to prompt a little bit more with these skills to see if they can pull some points out for him. So he's lost his points for commitment especially, maybe one for the med ed bit, but now we're going to move into a skills-based question.
Skill sets are you looking for, do you think?
I think to be calm under pressure, a good team organiser, a manager, and someone who can sometimes step back and look at the broader picture in terms of where you're going with a patient.
So he has listed some of the skills, and those 3 skills are on the person specification, but again, there's no backup there. There's no examples of how he's used them. There's no reasons as to why they're important. So he's probably going to score 1 point at most for that section and 1 point at most for commitment to specialty, which is then really bringing his chances down of getting offered a good job for him. And if you were asked this and you'd done the prep and someone said, oh, what skills do you think we're looking for this specialty or for this F3 job? You would be able to just go, oh, which one do you want? Here's time management. This is what I did. This is when I developed it. This is why it's important. Here's coping with pressure. Here's my example of it. Here's why it's important. They would stop you after a couple and be like, yeah, you've got full points. Let's move on to the next section. And you can really tell somebody who's been interview prepped and trained for an interview because they know what they're doing. They know how these points work and they know how to be able to answer them. In the trust interviews, it might be that you get a specific skills question. So sometimes if you've done an interview really well, you'll have had questions about you where you'll have talked about your top skills. You'll have questions about the job where you'll have identified skills that are important to that job and give some examples of them. And it might be that you get to this section and they say, right, we're going to change the way that we ask the questions now, and we're going to ask you some questions that are very specifically skills based. And you might have already done a fair few of your skills, which again is why if you've prepped, you will have the extra ones to be able to talk about. But sometimes the assessors will say, actually, we're going to talk to you about skills now. You have mentioned some of these already, but it might be just to draw on those a little bit more. So these will be things like, can you give me an example of a time when you've worked in a team? Or can you describe a situation where you've had to cope with pressure? It might be that they give you an example, so we're going to talk you through a scenario, and then can you let us know how you would deal with this? So it might be something like, you've turned up at work, it's really busy, there's a 4-hour delay in ED, the nurse is asking to see you, this patient has got this on their result, the consultant wants you to do this, the admin team have asked for this information, and then you have to talk about how you would prioritise what you were going to do and organise yourself to be able to do it. So it's a skills-based question around testing that skill, but they're giving you some of the scenario to talk through. It's always good as well to have a strength and a weakness. So always have, this is what I think I'm strongest at for the skills. One of them off the person spec. Actually, I think communication's my strongest skill. Have an example ready of it. It's also really important that you have a weakness as well. You might straight out get asked, what's your weakest skill or what's your area of development? And you can look a little bit arrogant and also like you've not got a great level of self-awareness if you're not able to answer that you've got any weaknesses. It looks a little bit like, you know, you think you're great and you haven't got anything wrong with you, which we know we all have. So it's good to have an area of development. If anyone was to ask me in an interview, what's your weakness? I would say time management. Time management's a problem for me because I have a very busy job, I have a very busy life, I have lots of things going on which sometimes can get difficult to manage. How I manage this though is I share a diary with my husband so that we can see each other's commitments. At busy times of the year that I know will come up with my job, I delegate other things to family and friends to be able to support me. I have a schedule of things, so I work ahead of time so that everything's booked in and sorted. So you see how you're seeing, I have this weakness, but this is how I overcome it. And actually it wouldn't impact if you employed me because I'm able to manage that. So it would always be good to have one of those as well. So I'm going to show you an example of somebody being asked about a skill. And this skill is reflection. So you've got two candidates here who are asked about a time when they've made a mistake and how they reflected on it. I just want you to have a look at this video and see which one you think answers it the best. Is it candidate 1 or is it candidate 2? The first candidate does get asked 2 additional questions, but I will run through those and how they answered them and how you should answer them.
Panel interviews are still an important part of the assessment process. Here they last for 10 minutes, and each of the assessors probes the candidates on one area of their professional practice.
My question to you, Roshi, is could you describe a critical incident or a situation that you were involved in a clinical mistake? What action did you take and what did you learn from the experience?
That it was when I was house officer and I was prescribing gentamicin for a patient and I looked up in BMF and the dose was 240 in 3 doses. I interpreted that for myself that it was 240 mils 3 times a day. So literally I prescribed treble dose that I should have. But luckily enough, one of the nurses picked it up before giving it to patient. There wasn't any harm done to the patient thanks to the nurse who was looking after the patient. But I discussed it in the handover the next morning. So what we did, we wrote a letter to BNF and we requested a change. Because sometimes they do write like 240 3 times a day, but there was 240 in 3 doses. So it could be very similar for some, inexperienced doctors like myself at the time. So, we saw the change actually recently in the latest BNF.
What are some of the reasons that you're aware of as to why doctors don't pull their weight, come up to the mark?
Well, family, social lives, maybe they've been outside drinking too much and they have a hangover, we don't know, do we?
And who do you think are the best judges of whether a doctor's performing well?
Well, actually, I think every member of the staff in the department can be a good judge. It can be the patient, it can be junior colleagues, senior colleagues. So I think probably the thing we recently do in our portfolio is a 360 degree of competency. That is something which you give to different people, and they give you feedback of how your performance is, and that's really good thing I think to do. I think everybody can be a good judge. I don't think it's necessarily the senior ones who are good judges.
Right. Okay, that's great. Thank you very much.
Okay,
Susanna.
pleasure.
Susanna, can you describe a critical incident or a situation where you were involved in a clinical mistake? What action did you take and what did you learn from the experience?
Okay, probably draw some experience from a patient we had recently. I was doing a gynecology on-call and I was the first on-bleep holder. Admitted a young girl, known endometriosis, had repeated laparoscopies, well known to the team. But then actually she did become quite unwell. Nurses reported she'd spiked a temperature and we hadn't really redone her bloods, thinking there wasn't much else going on. Redid them, the white cells had shot up, CRP was going through the roof and she was actually getting much less well. So we thought, well, we've obviously missed something here, what's going on? And we had been examining her and pain was on the right side. So we eventually got our surgical colleagues to come in and see her, and they said, well, you know, clearly she's got an appendicitis. She's obviously now got quite an acute abdomen, she needs to go to theatre. It told us that actually you need to maintain sort of 360 vision. I think we'd become a little bit complacent. I always now try and just think a bit more widely for all of them.
So if we're looking at these two candidates, it is candidate one who answers this better in terms of how they will score. So what I'm showing you now is not something that's used in the interviews. I'm just giving you a little bit of an idea as to the weighting of the scores for these types of questions. They wouldn't be scored to this extent with a score of 21 for one question. It's still out of 4. But you can see that if we looked at it as a score of 4, you're probably getting 1 point for just describing what the situation is and setting the tone. Your first one did that very quickly. She's going to give the wrong amount of medication. So it's clear what the error was. The second one really waffled quite a lot in that answer. It wasn't clear what the error was. Was it just that they were complacent, that they didn't check the bloods, that they didn't get other people involved early enough? You're probably going to get within that point, you know, taking responsibility for the error, which the first one did very clearly, but the second one said we all the way through. So it was a little bit difficult to see what her role was within that error. But the big parts of the point are coming from the skill, which is reflection, because no one's scoring anybody's error over somebody else's error. So what you're getting your points for is the outcome of the situation, a reflection on that experience, what you've learned, if you put any changes in place, and the results of any implemented changes. Now, I think what's happened here is if you're in an interview and someone asks you a question like that, can you give us a time when you've made a mistake? Your brain stops listening to what that assessor is now saying and starts going off into what can I answer on this? What mistake can I use? Can I use that one? Is that one too bad? Should I go into detail on that one? I don't think that one would look good. You're off. If the second one had just took a minute to go, there was something else that they said there on the end of that I didn't hear. Let me just check. You can ask, okay, I've thought of what my mistake and the error is, but can I just check what the rest of the question, the end of that question was? You would have heard them repeat that question and you would have understood that actually there it is, there's the skill, that's what they're checking. This has to go back to the person's specification. What is on that person's spec that they would be scoring as part of this? There it is. What did you learn? Reflection. And then maybe she would have done a bit more on the back end of that, because the first one's going to score quite well. This is what went wrong. This is what we changed. We've seen the change. Whereas your second one is going to lose loads of points on that scenario because she just didn't give enough on the end of an in-depth of reflection and changes on it. The first one was also asked those 2 additional questions, so we'll just cover those. So she was asked, why do you think that junior resident doctors don't pull their weight, come up to the mark? So if we think about what is that scoring, how does that relate to the person's specification? Because I don't think that the assessors really care about her opinion on, you know, why junior doctors might not come up to the mark. So what can we pull this back to relate it into something that is being scored? If we think about the person's spec and the skills, and we answer that question with any of those skills, So let's take some of them. Resident doctors don't come up to the mark because teamwork. Sometimes it's really difficult to feel part of a team because you're rotating every 4 months and you have to re-establish yourself as part of that team. So sometimes it can be difficult working in a role when you're brand new in a team. You don't know where things are or what people's names are. Coping with pressure. It's a really big transition going from a student to becoming a professional doctor. It's quite a step up. It comes with you're in and you're running on your feet, and sometimes that can be really difficult to manage. Time management. You are having to do the job, deal with the nights and the rotas, as well as manage your time enough to be able to still be completing a portfolio for an ARCP, as well as possibly preparing a portfolio for entry into specialty training at some point. So that can be quite difficult. Do you see how we're taking any skill off the person's specification and using it in that example? And I think that is just a really awful way of asking the question of a weakness. What is the weakness of a resident doctor? And it can be any one of those. So I think if you're getting asked a question and you're not sure about what's this behind and what this might be scoring, always think back to that person's specification. And if in doubt, just link to a skill if you can, because it might be that you'll pull in a couple of points rather than having no idea and just kind of waffling on about something and hoping that it might hit it. If it's skills based, it probably will. Okay. Just a little bit of extra around the teaching fellows and the F3 roles. So if you are going to go for a teaching fellow, it might be that you are asked to do a mock teaching session. Most of the trusts did this before COVID, and then after COVID they were just doing a Teams interview where you were doing a presentation. But I'm wondering if some of the trusts are starting to bring back the mock teaching sessions now. If you do have to do one, it's normally a 5 to 10 minutes. It's a very short one. They'll either give you a topic or you can do it on a topic of your choice. It's normally to the third year medical students or to the current teaching fellows. If you don't have to do one, then it's likely that you'll have to do a 5-minute presentation to the panel. I think most of them are still using Teams for their interviews. I don't think they're back to face-to-face yet, but I could be wrong. They might start bringing them in soon. So if you do need to do a teaching session, it's just to let you know a couple of the things to keep an eye out. So you are probably going to be scored on some of the things that are on the screen now. So it's how you make the topic interesting, how you approach delivering the teaching, the resources that you use, if you're using PowerPoint slides, and how you make them interactive. There will be an opportunity to ask questions probably, and it's likely that someone in the room will ask you a question because you're likely going to be getting scored on how you approach that and how you answer that question. Remember that you'll be being scored on your presentation style. So whether that's teaching or whether that's a presentation, this is about eye contact. It's about open body language, your pitch, your tone, your use of jargon. It's that kind of presentation style that you need to work on as well. So if you are doing it, prepare it, do it a couple of times, record yourself doing it so you can check yourself back. I have, it used to be in the past that if you went with additional things, like if you went with leaflets and things like that you got extra points. But in the world of sustainability now, it probably wouldn't be a good idea to turn up with a pile load of paper. Might be worth though putting some links or QR codes or something like that onto your PowerPoint slides if you're doing them, for people to be able to then go away and link into those. For the interviews, it's pretty much everything that I've done with you, but just to pull out a couple of things. The teaching fellow, make sure that you fully understand the role of the teaching fellow, not just your exposure to the teaching fellows during foundation. So you do need to understand that whole pastoral mentor side of the role as well as the teaching. One of the trusts one year was asking questions around how you would manage being someone's friend and mentor, but also then possibly having to challenge them or have conflict with them if you were failing them. So one of the questions was around that. So it's just to help you to prepare. The rest of them are around everything that I've done, why you want the job, what you know about it, your skills. When you are going for an interview for specialty training, it does not matter where you want to do it. So you don't need to be talking about doing it in Northern, you don't need to be name dropping any consultants or anything like that, because it's a national process. Geography doesn't come into it. But when you go for the F3s, it really does. And I'm afraid you do have to cheese this up a little bit. You do have to do your research and really be on the ball with this. So you want to be looking at, first of all, the trust. Why do you want to work for that trust? You need to know the trust's values. That's really important. Every trust has a number of values. It's 4 or 5 different things that they'll want from any employee. And these are normally words like innovative, compassionate, patient-centred, caring, those kinds of things. You will find them on their websites in the About Us section, or they might be on that front page. Make sure you know them. You might be asked outright, what are the trust's values? And if you don't know them, that's a really awkward 2 minutes of answering that. So make sure you know them, but also make sure that you have an example of at least one of them to show how you've worked within that value during your time as a foundation doctor. Then you want to also make sure that if you're going for a clinical fellow or a trust grade and it's in a certain department, that you've done your research on that department. So, you know, go onto the consultants' LinkedIn profiles, see what they've been involved in research-wise or publication-wise. Go onto the department's web page on the trust's website, because you need to be able to be like, you know, I'm applying for this trust grade in Durham because actually I know that you guys have done a lot of research in this department around this and I've been interested in it. You need to be able to show that you've done something and that you're not just applying for any single F3 that comes up. I know you are, but we don't want them to know that you are. And that is pretty much all of the prep that you can do for a specialty or an F3 interview. So I can't stress enough, make sure that you go through this, make sure that you've prepared your answers, make sure that you have your examples of your skills, and I guarantee that that will be an easier interview if you do this. So good luck. I hope you get everything that you're going for, and I hope that this video has been useful. Thank you very much.